ex-colleague Andreas Colleris from Thessaloniki, from Sandoz Hospital, to have this presentation of aspirin hysterectomy again minimally invasive.
Just a moment for technique. Karl Pavlik was the first one who described the radical vaginal hysterectomy. And one of his students was Friedrich Schauter. Friedrich Schauter was the director of the first university clinic in Vienna, who actually systematically, one of his students was Ernst Bertling. I stop now with the history and I proceed with my subject. My subject is the nerve-sparing radical procedure, radical hysterectomy. I will focus on the surgical steps that can cause damage to the autonomic plexus and especially of the bladder branch of the plexus. With my video presentation, I will try to demonstrate you how my team performed this kind of nerve-sparing procedure, and we don't have uterine manipulator, never. I'm coming from a school. I start from Friedrich Schiller University of Jena under Professor Achim Schneider with the same board with Markus and later Christa Köhler. I learned the laparoscopic assisted vaginal radical hysterectomy, the Schauter's method, and later as a vice director of the University of Lübeck, I performed my own technique, total laparoscopic nerve-sparing radical hysterectomy until now. Now we will proceed with the identification of the inferior hypogastric nerve. There are two ways to perform. It. The first one is by mobilizing the ureter away from the uterosacral ligament and the lateral rectal wall. The ureter and the inferior hypogastric nerve are 2 to 3 centimeters below the ureter. This is the inferior hypogastric nerve now. And the second way to identify the nerve is by in the area of promontory. You can identify in this area the superior hypogastric plexus and then follow downwards the inferior hypogastric nerve. The second part of this surgery is to identify the cardinal ligaments. The cardinal ligaments are the median support tissue. Of course, this is a patient with very low, you have to identify the nerves, otherwise you will cut the nerves or damage the nerve, especially in a patient with a very low BMI. In this point, I realized that I'm too close to the bladder branch of the plexus. This is the urethral branch of the uterine artery. So I changed my following steps, of the bladder branch of the plexus and then of the plexus. Because I realized with this low BMI, maybe we can damage the nerve in the usual procedure. From the sacral root to the inferior hypogastric nerve to the plexus. As you can see, we work with a lot of dissection. I use 2 Maryland graspers. Both are bipolar, so I can calculate left and right, and I calculate as less as possible. Now is the last part of the dissection of the cardinal ligament to achieve in this small cervical tumors now for ureterocarpayashi and the Latsko space. Inspect the whole specimen. This is how I learned it. We documented everything and we follow up everything. Dr. Ziguris for the best abstract award. And again, thank you very much, and it was a great time, David, and I hope that we will have another SAGO congress in the future. Thank you very much.
I think it's time for a break.
I think we have a question here. Do you offer your cervical cancer patients, once they are aware of the lab trial findings, a choice of open or robotic radical hysterectomy, or just loosely do open radical hysterectomy? I mean, this is more probably to both of us.
lab trial, we have actually the past 4 to 5 years in every congress this debate. Of course, we have the ESGO guidelines. We have to respect them. We belong to ESGO. And of course, when I have a patient with more than 2 centimeters of cervical cancer, I have to explain to her about the guidelines, about the data, and what is the recommendation of our ESGO society. But there's a big but. I can explain to her that the surgery it will perform, but I will explain to her that we have also a very good data for 40 years of data, and the surgeons are still the same, the team are still the same, and the patient should decide what she wants to do. If you ask me about the percentages, 80 to 20%. 80% they will decide to do it laparoscopically. 20% they will decide to do it with open surgery. So the gynecologist decided to perform laparoscopically the radical hysterectomy. At this point was very interesting that it starts also the manipulator, the uterine manipulator. We have a lot of new coming manipulators. I speak about 25 years ago. And they were actually for the simple laparoscopic hysterectomy. The big problem that comes 20 years later is that the ESGO and the gynecology community didn't understand that to perform this kind of surgeries, you have to be specialized in gynecology and in laparoscopic surgery. Because the institutions, the clinics that they were expert and they have also expertise and experience in this kind of surgery and in gynecology issues, they never use manipulator. Because to learn how to perform laparoscopic radical hysterectomy, you have to start from the simple laparoscopic hysterectomy. So if you learn to perform a simple laparoscopic hysterectomy using uterine manipulator, then you will adopt this step automatically in your advanced surgery, in your laparoscopic radical hysterectomy. And this is what happens historically again, 25 years ago. So I wish, if I could wish, to have these updates of the ESGO guidelines 20 years ago. Then we will not have the data of the lab trial, because the lab trial is actually the bad result of our community as gynecologists. Yes, it's difficult, especially if you have a high BMI index, but we have a neurotransmitter, neuromodulator to find the nerves, but easier is if you wear loops, magnification loops. If you wear loops, you can better see the nerves. And of course, if you have the experience from the laparoscopic way of finding, of identification of the nerves, then that helps you also in the open surgery. This is a tip from me. Use loops.